What's going on, podcasting world, and welcome back to another episode of the Core Consults RX podcast. My name is mcorvino. With me, as always, Cole Swanson. Cole, what's going on, man?
Doing great. Ready for another late night session.
I know. It's 10:24 p.m. right now.
Yes. Getting it in before the end of the month.
Yes, trying to. Got to meet our quota on numbers.
Right. Got to get them all. We cram them in, it's fine.
Yeah, it's good. It's whatever. But so we got one more day left tomorrow in the month.
Mm-hmm.
And this month already set a new record by a lot for downloads.
So thanks, guys. Y'all are awesome.
Thank you all for actually listening to us. We are as stunned as you are that
every day
listen to it.
I don't get it.
But I've even gotten some emails recently, and even the ones that have been like giving us some information, like correcting some of the stuff we've said. They've all been like super cool and supportive about it.
I'm fine with being correcting. I feel like we got corrected more at the beginning than we do now.
Yeah,
or at least I felt like I was correcting myself like on the next episode more than I do now.
Yeah, we definitely still say some stupid stuff.
It could be I just don't care as much as I used to.
Maybe.
I'll just say whatever I want. You know?
Yeah, I mean, who cares? Get a podcast.
When you're a student, I think you're a lot more worried about getting stuff right.
Yeah, no, I think we mess up most when we take on a subject that's like way out of our scope of
It's about
80%
of the time.
Yeah, so I'll take those odds any day of the week. Oh man, so we don't have like an actual full-on topic for you guys today. So we're actually going to cover a patient case. So we do these every once in a while. A lot of times we cover some of the same disease states, but review is good.
Yeah, it seems it almost, when you hear it, like, oh, we're talking about diabetes or post-MI or something like that, again, it sounds redundant. But there's so much to these, especially diabetes. It really can't be reiterated enough. Plus, I feel like we take a different angle every single time we talk about a patient case anyway. And these are real people, so pretty practical.
Yes, there's a patient that I saw this week. And we're going to kind of go through some of it and see what we think.
Yes.
So kind of starting off, 57-year-old Caucasian female, came to the clinic for diabetes education primarily. She was referred to me from her PCP to manage her diabetes and look at her pharmacotherapy, as well as kind of just overall pharmacotherapy management as well. And we will I'm going to skip a lot of stuff for time's sake, but to give you the general gist, the first thing she said was that 98% of the time she takes her medications. So I was pumped that she gave me such a solid, perfect answer of 98%. It's hard to calculate, but she hit it right on there.
She takes it 29 and a half times a month.
Yeah, she's super confident.
Yeah.
And then she really wants to stop some of her medications, so that was her other thing. She was like, I really want to come off of some of this. Past medical history, she's got hypertension, reduced ejection fraction, heart failure, diabetes type 2, she's got asthma, neuropathy, osteoarthritis, insomnia. She has had an MI back in 2014 and is still a current smoker. Smokes a pack of cigarettes per day.
Great.
Yes. A1C, because she takes her medicine every day. A1C today is a 9.5, and blood pressure was 172/91. So wasn't super thrilled about that.
Not thrilling.
It's been above 9, actually 9.5 in January. It's been there since January this year and going further back as well. But blood pressure has always been higher than 160. So she's been uncontrolled with just those two things alone. Also, she's been using her albuterol rescue inhaler because it's the only thing she has at this point. Been using it 4 or 5 times a week, and it's been a cost issue as far as getting anything else. But she doesn't use anything except albuterol by itself. Medications, she is on glyburide, pioglitazone. She is on insulin, Lispro, or Humalog 3 times a day. She's using 15 units with each meal. She's taking Levemir, 15 units twice a day. And she's taking atorvastatin, 40 milligrams. She's taking metoprolol, succinate, 50 milligrams. Losartan, 100. Lasix, 40 milligrams as needed. Taking Plavix, 75 milligrams. Aspirin, 81 milligrams. The albuterol, like I mentioned, taking 50,000 unit vitamin D once a week, taking gabapentin 600 TID, taking trazodone 100, 2 of them every night, using Flonase, 2 sprays in each nostril twice a day, and Celexa and diclofenac for the osteoarthritis.
Nice. So
So
that's pretty. That's pretty standard stuff, man.
yeah.
Like it's unfortunately this is what it looks like.
Well, the unfortunate part is actually took out some of the meds she was on just for time's sake, so we can talk about
Right.
this. But yeah, there was actually more than that. But I was, like I said, she was supposed to be there for just primarily diabetes management. But when you see a disaster like this, sometimes you have to mess around a little bit. So
Funny thing is, you can go in and find like a reason for it all. Most of it, all but one. But it's just not highly justifiable, it seems.
yeah, for sure.
So looking at her, I guess the first thing I would do is prioritize. So her A1C is above goal. It's floated around 9.5 for the last few months. Blood pressure is also well above goal too. Fortunately, we'll be able to kind of kill a couple birds with one stone with that as well. There's obviously a lot of stuff you could change with her. You already mentioned the cost is an issue, so you got to keep that in mind. But hopefully we would kind of take it reasonably slow and not do like 10 things at once. Have her follow up relatively soon, make another switch, and keep it going like that.
Yeah. And that being said, the clinic that I work at is does have a 340B pharmacy, so we have meds cheaper than much cheaper than she'd be able to get somewhere else. So we were able to work with her with the prices. So we'll talk about that as we go.
Who can get meds from you? Do they have to qualify for 340B?
No, anybody can. They just have to be seen in our clinic. So one of our providers has to see them and prescribe it. They can't go see someone from an outside provider, bring in the prescription, and have the pharmacy fill it.
So who can see y'all's providers?
Anybody. Yeah, we have
that
some
right?
people that are wealthy that live on the Battery, and they just come there because it's convenient. And we have other people that are homeless. So
How
it's
interesting.
completely broad spectrum. Yeah, it's pretty cool.
That is pretty cool.
Yeah,
I didn't know that.
Yeah, and it's a really fun place to work.
So it's not just like low income, no
no,
insurance.
no,
type
no,
thing?
no, no,
Okay.
no. There's a bunch of MUSC students that come through.
Oh yeah.
Yeah, because it's, in my opinion, better than going to the student, med.
Yeah.
Or what do they call it? It's that student clinic.
Student health.
Student health.
Student
Yeah,
health,
that's
yeah.
the word I'm looking for.
Yep. Okay, so diabetes first.
Yeah, let's do
Might
it.
as well.
Yeah.
So she's on glyburide, meh. She's on Actose, meh. And she's on Humalog and Levemir. It seems to be adherent as far as we can tell. We know we don't love sulfonylureas in diabetes. High risk of hypoglycemia, potentially increases risk for heart events long term. She's already post-MI. Also, Actose concerns with worsening heart failure, like other drugs in its class. Rosiglitazone, very bad in heart failure. So for those two, we probably want to look into going ahead and switching, right?
Right. Yeah, and if you look at the new ADA guidelines from 2019, they have the two medications that they do recommend if cost is an issue, would be sulfonylureas and TZDs. That being said, luckily we were able to see her at our clinic so that we could get her much better medications for something that she could afford. But that's, an option that a lot of people don't take advantage of. Either they just don't go see the physician or they stay with their primary care doc. That's not able to get them cheaper drugs instead of finding patient assistance, because there's definitely a lot of programs besides ours. And then a lot of the drug manufacturers now, which we had to utilize for her, which we'll talk about. But one of the drug manufacturers actually got one of her medicines for free, and they paid for it. So
good.
There's a lot of different things. Novo Nordisk, Lilly, a lot of them have patient assistance programs.
Yeah, and even as far as cost issues go, metformin is a very easy thing to add on here, which generally I would consider that an extremely low cost drug, close to the sulfonylureas and probably cheaper than Actose for the most part.
Right.
And it added on to insulin has been shown to reduce insulin requirements and improve A1C long term too.
Yeah, and if you look at like the home trial, which I think is what you're referring to, they actually had as much as 19 units that they could decrease the insulin dose when they added metformin, as well as preventing MI and stroke, which she's already at high risk for since she's already had an MI, and so I think metformin for her would be very ideal.
Right.
She has a lot of health issues, obviously, but she's only 57. But it's hard to calculate what her 10-year life expectancy is, because we're just now getting her on some of the medications that she should be on, but it's hopefully we can prolong her life and make sure we can get the full benefit out of that metformin,
right,
and some of the other drugs we decided to use.
Yep.
All right. So the other thing is we looked at her blood glucose log, and to give you a couple of examples, it looked like Sunday morning she had, for example, 275, and then before lunch that same day she had 127, and then before dinner it was 203. On Tuesday she had a fasting in the morning of 280. Before lunch it was 68, and then before dinner it was 165. Friday, just to give you another example, it was 310 in the morning, 145 before lunch, and then 212 at dinner time, and the next morning it was 254 again. So
it seems like fasting, big issue.
Right.
Before dinner, big issue. Some lows around lunchtime. Exactly.
And kind of the more we kind of prodded the questions, found out that she was using the 15 units with each, quote unquote meal, but wasn't necessarily eating breakfast. So that was one of the problems, because she would be high in the morning. So that was kind of covering her, even though she was not eating with her insulin.
Right, not that kind of high.
Right. It was, her blood sugars were high. And so it was bringing her down to, before lunch. However, it was sometimes taking her too low because she wasn't consuming any carbs at that point. And then that being said, she would miss her dinner time dose sometimes. And so a lot of times she would be eating, plus the diet was a whole separate issue. We won't even go into some of that right now, but her diet was not the best. And so, she's eating a high carb lunch. The insulin's not carrying her over to the dinner time. And then she was not taking her insulin at dinner. So it was making her fastings and stuff worse the next morning. The other thing to consider is, and this is something that she was kind of bringing up, is she's like, well, how was my blood sugar? She was checking it sometimes before bed. No, not very often, but sometimes she'd get a before bed reading, and she would say it's lower before bed than when I wake up, it's even higher. So how can that possibly be? If she's sleeping and she's resting, shouldn't it come down? And I think that's kind of like a common thought amongst patients. But I kind of explain, like, if you think about it, your body needs the sugar for cellular processes and cellular functions. Well, when you're sleeping, that's your body's time to kind of repair and get ready for the next day. And so your liver stores all this sugar, and then it just starts releasing it overnight, and it goes in the blood, and it's not able to go to those cells where they need to for the energy, and it just stays in the blood. So you wake up, it's even higher. And I explained it to her probably even more simply than that, and she understood, because at first she was thinking that there was something like wrong with her physiologically or something compared to everybody else. So giving her a little bit of a very, very brief physiology lesson sometimes can help, because she seemed like she was thankful for somebody taking the time to actually explain some of this to her.
Yep.
So it was cool. All right. What else is cool with this one? You've been talking the whole time.
Yeah. So, for cost purposes, we'll probably leave her on the Humalog and Levemir. Levemir is twice a day, though preferably one of the long actings like Lantus or Tresiba is generally preferred. Lower risk of hypoglycemia, just more consistent levels throughout the day. You're going to have less peaks and troughs. But that's fine. We'll keep her on that and kind of titrate as we go if we're switching around some meds. I know Mike mentioned that they actually did this, but you could look into, depending on the situation, potentially getting a GLP-1 and adding it on in place of the glyburide and Actos with the metformin. That would kind of be the group of things that you would change if they can afford it. So she was able to get on a assistance program, which they were able to get a GLP-1 covered. So they were able to do that. But ideally, that would be good, even in addition to the insulin. Some people think you can't do them together. You can.
Yeah, and so the very first thing that we did do is get rid of the pioglitazone, because even if it's just strictly a cost thing, like she's got reduced ejection fraction heart failure, and it was beginning progressively worse. So the pioglitazone is definitely not helping. So we got rid of that, and then like you were saying earlier, called the metformin, we added on. There's a really low dose, and then we were able to get her on the Lilly program. Lilly Cares is the name of the program that Lilly has, and get her enrolled in that to get Trulicity. So they're shipping her Trulicity. They cover for like a year of it.
Awesome.
we discontinued the Humalog and started the Trulicity instead, because now, and if you guys think about it, I'm actually a big fan of doing this because, one, it cuts down on the number of injections, which is great. She wasn't being adherent. She wasn't keeping consistent meal times. Sometimes she wasn't eating breakfast at all. So if you think about like a GLP-1, it's only activating when the person actually consumes carbs and when the blood sugar actually spikes. Then it's going to turn on, it's going to increase insulin secretion, and it's going to decrease glucagon, which is going to suppress, glycogenolysis, gluconeogenesis, all those processes that can result in high blood sugars, as well as, affect her satiety after a meal. She's going to feel full quicker. She's going to hopefully have some weight loss. So all good things. And we don't have to worry nearly as much about hypoglycemia as we do. So for us, now since we got it covered, that was like a big win, because she was super excited too, because nobody wants to take 4 injections a day if they don't have to.
So getting the Humalog off would be great, even though she's reports being very adherent. That would take, 21, 28 injections a week to 1. So that'd be awesome. And
we just went ahead and had her do the Levemir just once a day with 30 units instead of 15.
Gotcha.
Just because she was separating it for not really any particular reason. She had a friend of hers that was doing that, so she started doing it.
Oh, really?
Yeah. The other thing is too that, and this is actually something that I don't think a lot of people think about a lot, but the glyburide, the sulfonylurea. If we think about like how a sulfonylurea is working, if somebody has insulin resistance or a decrease in insulin secretion, especially like this lady would probably have, a sulfonylurea is taking activating the pancreas whenever you take one, and it's just kind of like squeezing the life out of it to try to get every last little drop of insulin that it can possibly produce. And you're putting the whole idea of kind of giving insulin and things like that is to give the pancreas a break and to decrease any kind of like glucose toxicity or anything like that that's going on. So if I'm giving glyburide on top of that, I'm just basically I'm putting stress back on the pancreas and causing some issues long term, most likely. So sulfonylureas, if we can avoid them, that's the reason why they're more like 5th line now for the American Diabetes Association, because they're not mechanistically, they're not that great of a drug.
Yeah, and long term they can lose their effectiveness too for that exact same reason.
Yeah. Plus, glyburide is the longest acting one.
And of all the ones, it's really
it's probably the worst.
Yeah.
So it's got the most chance of having a fall risk because of hypoglycemia. Plus, when you're on insulin as well, so it's just all kinds of bad with her.
Why do people use glipizide extended release?
Glipizide extended release, or a lot of times they use it once a day, but we've even have some patients that use it twice a day.
So the idea is just less doses, but I would suppose it would, similar to the longer acting sulfonylureas, it would increase your risk for hypoglycemia more.
Yeah. I haven't seen any studies that show where they've compared it directly. I've just seen the ones that look at like just metformin versus sulfonylurea and things like that, where the metformin blows it out of the water.
Right.
So stuff like that where it's just they're not great. I'm becoming less and less and less of a fan of the sulfonylureas.
We were already not a fan, and then it was like, well, maybe they're not so bad. They're cheap and everything's fine. And it's like, well, no, they're just not very good.
Well, and especially the situation that I'm in, I feel bad if for those who are in primary care that don't have access to the cheaper drugs, because then you're kind of really limited. I have a lot more leeway because of the 340B pricing.
Yeah, I totally get it with you're going to take those risks to get a patient's A1C down if there aren't any other options. But there's no reason for her not to be on metformin at least before even going to those sorts of things. Anything else for A1C control?
That's kind of what we started. That's the most changes I've ever made in one visit, but it was just such a disaster.
So I would say that's pretty much the most you want to do in a visit, and then follow up. Probably
3 weeks. We told her 3 weeks.
2 to 3 weeks would be great. So that's where you would go, and the idea is to kind of titrate those things, get the Trulicity up to the 1.5, titrate the Levemir as needed, and hopefully keep her on the Trulicity, metformin, Levemir going forward.
Right.
Get it down below. The initial goal is just to get it down some, and then bring it down to 7 or 7.5 or whatever you decided the goal was for her.
Yeah.
So I guess next, acutely, so her blood pressure is 30 to 40 points above goal, whichever guideline you're looking at, pretty consistently. So next visit, if not this visit, probably want to start tackling that. In addition, you'll be able to tackle the heart failure at the same time. So fortunately, a lot of times with heart failure, when you're maxing these blood pressure medications, which we'll talk about a little bit, to the goal dose, you have issues with patients' blood pressure going too low. Seems like this lady's got quite a ways to go as far as blood pressure goes. So you got a lot of room to squeeze it. Along with that, high blood pressure, heart failure. She's already had an MI. She currently smokes, so she's very high risk for another one. So getting that blood pressure under control soon, I think is going to be important.
Yeah, and if you look at her meds that she's on right now, she's taking losartan 100 milligrams, and she's taking metoprolol succinate 50 milligrams. So one of the things that's very common in heart failure, and now that I'm saying this out loud, because last time we talked about this in the podcast, somebody else emailed us and asked for the reference to this, and I'm not sure that I ever gave it to him on Instagram. But so I need to look that up again. But there was a study that showed, I want to say it was JAMA, possibly, maybe the Annals of Internal Medicine. I can't remember, but I have to look it up. I have it saved in my computer. But basically, they were showing how many people were not controlled with or not at goal doses, rather, with their heart failure, not on optimal therapy. And it was like, I want to say like in the single-digit percentages of patients who are actually treated.
That's the idea.
So, ideally, we would want to start with ACE or ARB, or Entresto as well with HFrEF.
Ideally, it would be Entresto.
Right. Unfortunately, we didn't have any way of getting her Entresto because she's didn't have the insurance. We even know what 340B. We still can't get that one cheap enough to where she could afford it, and so we're stuck with ACE or ARBs, which is fine for the most part.
Yeah, cheap and well studied anyway. So
yeah. She's on losartan 100 milligrams, which if you're looking at LexiComp or something is the max dose per the package insert, the labeling. However, in heart failure specifically, if you look at the guidelines, they actually recommend losartan 150. And the reason for that is because there was a study called the HEAL trial that showed that they had the mortality benefit and whatnot with losartan 150 compared to 50 milligrams. And the drug had just gone off patent as those results kind of came out. So the company didn't want to put up the money to get the label change. So they just kind of have it off label, but the guidelines do include and say 150 would be the gold dose for losartan.
There's gold doses for multiple things in heart failure, but as far as that goes, like lisinopril, it's not like you go up to 80 is the recommended dose or anything. It's still like 40, and generally they're just...
That's the one that's like this big one that's off label, like not a normal dose.
So if it hasn't been studied, then does it not have a gold dose other than just getting it to the maximally tolerated?
They do push all the beta blockers, because the beta blockers were studied to a target dose, and then the ACE inhibitors and ARBs usually were pushed to a target dose as well. Or like if you look at like the Atlas trial where they compared low dose to high dose lisinopril, and they got even though you didn't necessarily need the blood pressure lowering, which in this patient we do, but you still got the added benefit to having, as far as outcomes go, for having the higher dose lisinopril. I think they used 35 milligrams.
Gotcha.
And so yeah, it's kind of
random dose. Good.
Yeah. But so losartan is definitely an option. If we needed to switch to an ACE or something, we could. But she's already been on losartan, so I would just bump it to 150.
Yeah.
And leave it there. Now the other thing is the metoprolol. So she's on the right version of metoprolol, so metoprolol succinate. That's the one that was studied and shows mortality benefit. But the study that was done that showed the mortality benefit was the MERIT-HF trial. And during that study, they tried to target metoprolol succinate 200 milligrams. So she's not even close to being at goal.
Yeah, so you got a little ways to go. Also, post-MI, at least early on, being on a beta blocker is good for cardiac remodeling too. She may have initially been started on that for that reason.
Right.
And the other two evidence-based beta blockers, just for completeness sake, is carvedilol and bisoprolol, both of which have target doses as well.
And so the question is, especially when I'm talking to like students and things, is, how do we choose between those three evidence-based beta blockers? Do we just pick one? So one, I look to see if the person needs further blood pressure lowering. So this person does. So I'd actually be more of a fan of using carvedilol in this patient. If you think about the mechanism, the carvedilol is an alpha beta blocker. And so if we're just using a regular beta blocker, whether it's selective or non-selective, we're getting the blockade on the beta receptors, which is great. But then we have unopposed alpha activity, especially in the periphery. So that norepinephrine has to bind somewhere. So if we get activation of the alpha receptors, and we're going to probably get vasoconstriction over time in the periphery. So total peripheral resistance goes up. Eventually, that can outweigh the benefits of the decreased cardiac output, and blood pressure could kind of go back up again. So the general kind of rule of thumb is the metoprolol and the bisoprolol would be used if you didn't need as much blood pressure lowering, or blood pressure lowering wasn't that big of as much of a deal. And the carvedilol is if you do need further blood pressure lowering, that's going to have more effect. Right. And the other caveat would be if the person has COPD as well. Bisoprolol has been shown to be a better agent. It's more selective. I think it's like 14 times more selective for the beta receptors. Beta 1 receptors than the what's the word I'm going for? Metoprolol. I think is only like 4 times selective. So they're both considered selective beta blockers. So COPD, use bisoprolol. If you need blood pressure lowering further, then you can use carvedilol. Otherwise, any of those 3 would be fine. Just moving to the target doses.
If it doesn't matter, you can look at adherence to metoprolol and bisoprolol are both once daily. Carvedilol is twice daily. Might make a difference.
Yeah, that's true.
Otherwise, yeah. So you would hopefully that would be the goal going forward with these 2, get them up, or switch metoprolol to carvedilol since you want more blood pressure lowering. Monitor every couple to 4 weeks, as you are with diabetes, looking at how their blood pressure's ranging. You may also want to check some labs, potassium in particular if you're bumping that losartan up. And yeah, do we want to start her on spironolactone now, or go with that going forward?
That would definitely be the next step, especially if the changes in the blood pressure med, the beta blocker and the ARB were not enough to get her to goal. So I would definitely say spironolactone. If you think about like the Rails trial, we saw a mortality benefit in HFrEF. So that would definitely be the next step, would be to add on.
And goal for her would be 130/80 for heart failure. Mm-hmm. There's still some contemporaries hanging on to JNC8 I'm seeing.
They love it.
They do. They can't get enough of it. And they have issues with the new ACCHA guidelines.
I'd love to hear them.
Yeah, well, I'll show you what I'm talking about later on. But yeah still surprised by it. But
no, I see it as well. Or I see like 143 and be like, yeah, it's good enough.
Yeah,
close enough to JNC8.
Yeah,
but oh well. Well, if you haven't,
we don't judge.
We did even though I sounded just like I was judging. I judge a little bit.
I was apologizing for Mike.
I judge a little bit. It's fine. It's whatever. I like you as a person.
Right.
Just not your providing skills.
Yes.
So the that was our first episode, wasn't it? The new blood pressure guidelines, because they had just come out at the time.
Nostalgia, man.
Whew, I bet that episode is awesome.
Right, actually, as far as the first 10 go, I think that was probably the best of the first 10.
I haven't listened to them. I'm scared to.
Neither have I, but I can just remember, and I remember.
I think we might remember it differently.
I mean,
I might go back and listen to it.
I remember we had a couple guests in there at the beginning, and we only had 2 mics, and I don't know, it was probably pretty rough at the beginning.
Yeah, and the one mic thing was really bad. We were sharing a mic. That was super weird.
Well, that was great. That was the best.
Oh, man.
It's a good old days. Now we got more mics than we can use.
Yeah, now I got 2 mics sitting here and nobody's even on them. No guests. Anyways, okay. And she's also on the Lasix PRN as needed. So,
yes.
Cool.
No mortality benefit, but helps with symptoms.
Yeah. What else? Mention the cholesterol medicine?
No, we did not mention cholesterol medicine. So she's pretty high risk, of course. We kept talking about that. Also, I mean, obviously, so we did mention that she's had 1 quit attempt, apparently, for the smoking. She needs to try to quit. There's really, I mean, as far as all these things we're doing, I mean, there are some acute things with the high blood pressure and high A1C, but what's going to lower her risk the most long term is going to be for her to stop smoking. So we want to attempt at that every time you see her, at least mention it, feel it out, motivational interviewing and all that, see what we can do, consider meds if she wants some, and try to get her off of that. Otherwise, the best thing you can do to prevent secondary prevention is the statin. She's already on a high intensity statin, which is great, but and you probably want to get some cholesterol labs on her just to have just to see what's going on. But there really wouldn't be any reason why you couldn't bump it up to 80 milligrams anyway.
Yeah, and that's a big thing is 40 milligrams really isn't even the dose that's been study to show the mortality benefits. Always 80 milligrams for almost all studies except for like one that had 40. I think it was the ideal trial. The other, all the other studies, and like TNT is the one that popped into my head, was, the secondary prevention. Patients had some form of coronary artery disease, and then they were either put on 10 milligrams of atorvastatin or 80. And the ones that were put on 80 had better outcomes. The primary outcome of the composite that they looked at had a number needed to treat of 45. And so there was no difference in adverse effects. All that was good. So 80 milligrams, there's no reason to like titrate up a statin, in my opinion. I'm a much bigger fan of starting high and then if they need to, backing the dose down. I think we've talked about that several times, but something to consider.
We did hyperlipidemia pretty recently.
Yeah.
And we did smoking cessation semi-recently.
Did we? I don't remember.
Probably 30 episodes ago, but yeah, check that one out.
Yeah.
For all the motivational interviewing tips.
Oh, man. So much gold in there.
So much gold.
So the 80 milligrams of atorvastatin would be what I would go with her.
Yeah.
And then her goal LDL, according to the new 2018 LDL or dyslipidemia, really not even new anymore. Because I say that it's July of 2019. They've been out for like 9 months.
Yeah, that's true.
So now it's just old news. So her goal, because she has clinical ASCVD, would be less than 70.
Mm-hmm.
So even if we pushed her to 80 milligrams of the atorva and we couldn't get her down to 70, her LDL down to 70, we would probably want to look at using the ezetimibe.
Yep.
To push it a little bit lower.
Yep. Though patient wants to get off some meds, and we want her to get off some meds, especially when she doesn't need. So we see she's on Plavix and aspirin. Looks almost right because it's like, dual antiplatelet therapy. I think I learned about that. That sounds right. But there's really no indication for it. She had a MI in October of 2014, but really without stenting or anything like that, there really isn't a reason for her to have been on it in the first place. So it's probably pretty reasonable just to go ahead and stop the Plavix. Boom, just take it off. You can leave her on the aspirin for secondary prevention, but otherwise we're decreasing pill burden, decreasing cost, and decreasing risk of bleeding. So I say just get it off.
Yeah, and we couldn't find any reason why she was on that either. I think it was just a medication that was continued on and never taken off. Right. She did the year of dual antiplatelet therapy after she had her PCI from her MI. And,
she did have a PCI?
Yeah, but that was 2014.
Okay, so it could probably continue after that then.
Yeah.
Okay.
So probably not. I couldn't see any compelling evidence. This is one of those areas, though, that there may be some cardiology people that are screaming at me right now. You idiot!
Well, there could be some we don't know. Some we don't know going on.
Yeah, there was other stuff. Yeah, in her chart that I wasn't even dealing with this part of it. So when I say we're stopping, she actually is technically still on it because she's following up with her cardiologist that she hadn't seen.
So I'm going
time.
Based on what I'm seeing on this paper,
right,
but there could be more to the story.
Hopefully, he'd give us some more insight, but we didn't have some of that information.
But still, there's a lot of things that aren't optimized and whatnot, so it's not like we're putting all the faith in them.
No, we don't have a lot of faith in them at all, actually.
Got to have justification. Got to do it for a reason. She's also on nitroglycerin, so, I mean, she probably has, she, I guess, has some angina going on, too, so there's a little more to it than just what we're seeing here.
But she's also on a beta blocker, too, so hopefully that kills two birds with one stone.
Yes, especially if you're increasing it, then maybe you can look into, which is only as needed and whatnot, but just look into stopping it.
All right, so what else? We got the gabapentin she's on. Still having a little bit of neuropathy pain, but the big thing is, one, it's most likely going to be due to her blood sugar being high for so long. So hopefully we can get some of that to at least be reduced by the time we get her blood sugar under control. The gabapentin, she said, is not really helping that much.
Yeah.
So I'm actually more of a fan of getting rid of.
Yeah. So I would say another long-term goal, do some labs, check a B12.
Yes. See
if it's low. But you're right. It's probably because of the hyperglycemia. Get it down. If the gabapentin's not helping at all, we're looking at extra cost, extra pill burden, also extra weight gain, and potentially extra edema. She already has heart failure. So if we can get that off, that'd be nice. Also, I'd say let's get a vitamin D. She's on this vitamin D 50,000 units for who knows how long. For vitamin D is okay. Let's look into stopping that until it's low again. More meds we can take off.
And if it's still low and she's been taking it this long, we need to figure out what's going on. Maybe check her parathyroid. Yep. Check her renal function.
Kidneys, yep.
So the thing is with this is her renal function is definitely going to be an important thing to look at. Liver function too, because when you give vitamin D, cholecalciferol, or the ergocholecalciferol, the vitamin D3, D2, even if it's 50,000 units, that's the vitamin D in its inactive form. Still has to go through 2 different hydroxylation reactions. The first one's in the liver, second one's in the kidney, and then it becomes activated, or calcitriol is the short name for it.
Yep.
So that's the one that actually is activated and can allow your body to absorb the calcium. What can happen though is if in some cases we have patients who their kidney function is low and they're not able to activate this vitamin D, and we check a calcium level. Calcium level is actually pretty normal, and so we think, we'll just, no big deal. They're still obviously absorbing enough calcium, but what could potentially happen is your body is not getting enough calcium, so it's activating your osteoclasts in the bones to break down some of that calcium from the bone and reabsorb it back into the system, so it normalizes your calcium levels. However, you've now caused the bones to become more brittle, if you will, and the bone mineral density be decreased. And usually when that's going on, parathyroid hormone will be elevated. We should check phosphorus, things like that. The actual term for that is renal osteodystrophy. I believe they're still calling that. But something to consider. Kind of all those things are connected, so we got to make sure that we connect the dots. And it may be something as simple as just giving her the vitamin D, and
right.
it'd be fine. But making sure we at least follow up on the levels.
Otherwise, another change you guys were able to make is, so she has asthma. You mentioned she's using albuterol like 5 times a week, right?
Right.
Might be contributing a little bit to hyperglycemia, right?
Possibly, yep.
So then with new guidelines, see podcast 2 episodes ago, we can consider Symbicort PRN for asthma in people 12 years and older. You mentioned because of cost, she can't afford 2 different inhalers, a controller and a PRN inhaler. Mm-hmm. So it seems like the Symbicort PRN might be a good alternative to that, as far as using it less and not having to buy 2 inhalers.
Yeah, and so the thought process with the Symbicort, other than the fact that there's evidence for it, the reason the new guidelines push that as a rescue inhaler instead of the albuterol is because, one, the formoterol, the LABA, even though it's a long-acting beta agonist, it's actually got an onset of action of around 3 minutes. So it's going to be very quick, compared just like albuterol would be. So yes, it lasts for a while, but it has a quick onset, so you're going to get relief from it. The other thing is the inhaled corticosteroid is also on board. So if we think about the pathophys of asthma, it's an inflammation problem. So we want that steroid on board probably earlier than later. And when we're using it this way, we're decreasing the total exposure to the steroids over time. So then when they compared it to the studies that ended up being responsible for the new guidelines, they showed that when you compare this formoterol plus ICS, which Symbicort is what we ended up using, compared to albuterol, you had better outcomes with the LABA ICS combo as needed.
Yep.
So we ended up, because she couldn't afford to do an ICS every day and use the albuterol, which I still would have wanted to switch to Symbicort anyway, then we just went ahead and did the Symbicort as needed and called it a day.
Cool.
See how she's doing.
And you're able to get it for cheap, so
yes.
Not everywhere that's going to be able to work out.
Right. But we have it, Symbicort specifically worked out so we can get it very cheap.
Yep.
So that's good. So I use it to push the new guidelines.
So otherwise, she's on Flonase. Sure, whatever. She's on Celexa. I don't know if she had a psych doctor she was following up with, or if that was just primary care. That's fine too. 40 milligrams once a day.
Yeah,
no problem with that.
So the other thing is, she just kind of some more context. She was saying that she didn't really feel anything from the Celexa as far as benefit. So my thought process, and again, this is something that we have to change kind of from multiple visits because there's so much going on here. My thought process would be to switch from the Celexa to duloxetine, because she's also got the neuropathy. Mm-hmm. And it's approved for diabetic neuropathy. You're going to get some serotonin activity as well as norepinephrine. And so it may help with the depression as well. Mm-hmm. But it's definitely going to cover the neuropathy. And that's kind of, again, killing 2 birds with 1 stone, and we can get rid of the gabapentin, hopefully.
Right, yeah, take the gabapentin off. And alternatively, if it's not really working, but she's not depressed,
Yeah, that's the other thing. Yeah, for sure. She was kind of down, but it wasn't like, horrible depression, but it's something that she probably needed some.
She's been on it at a dose of 40 milligrams a day, and she's still depressed. You're going to look into an alternative either way.
Yeah.
Also, she's post-MI, Celexa, maybe not the best with heart issues. So, might be another reason to be able to switch.
Technically speaking, post-MI, the safest option, at least the one that we have data with, is sertraline because we got the SAD heart trial. But, again, in this particular case, it would probably be okay to give duloxetine a shot just because of the other issues.
If you can kill two birds, why not? Trazodone. I never know how to feel about trazodone, man.
Yeah, not a fan, especially 200 milligrams.
See, I'm not a fan, but the justification, which I totally get, is, it's better than Ambien as far as like risks and stuff like that, especially in elderly people. Don't get me started on the Beers criteria. You had that post recently. What was it that was on there? I think it was like trazodone was on there in the new post, and it was saying that it was the same risk as like codeine in people over 65 as far as increased mortality and stuff like that. And I was like, man.
No, it was tramadol.
Oh, tramadol. Okay, you're right. Not trazodone.
I was going to say, did I post that?
Yeah, I knew it was a TR. So okay,
tramadol.
It was tramadol, but still, I was like, man, I thought that would be a little better than Norco, but no, apparently not.
Yeah, and going with trazodone, there was a meta-analysis that came out not too long ago and showed that there is a lot of issues like the orthostatic hypotension that you get with it.
They mentioned trazodone in that same post. I can't remember if it was trazodone or tramadol, but one of them, I think it was trazodone. One of them, the increased risk of death came from like hyponatremia or something. It's like super random. Not even the reason you would think. I'd have to look at which one it was.
I have to go back and look at that too. I don't remember my own post.
I just remember it was strange. And I like to think the trazodone, I'm like, well, it's fine because at least they're not on Ambien. But there's issues with it too. Yeah. So there's the question, what is good for sleep in the elderly? My answer, I have no idea. What is good for sleep generally? My answer, I have no idea.
So I always kind of stick with one. Have we even discussed sleep hygiene?
Well, that's always it.
Kind of looking, when I mentioned it briefly to her, she's reading on an iPad, and sounds great because you want to read instead of like watching TV and things like that. But I've actually seen some studies which show that if you're reading on an iPad screen or a Kindle or something like that, it actually resets your circadian rhythm. I think it was like 2 or 3 hours back, compared to if you're reading an actual like book that doesn't have any sort of illumination to it. Now there is some, I guess, like different screens you can get now that can kind of help with that, but I'm not sure.
Yeah, there's the screens that don't have as much blue light. But either way, I think that's right. And generally with reading, apparently you want to make sure you're reading something boring. Like if you're reading something exciting.
Like pharmacotherapy.
Right, exactly. But if you're reading something that you're interested in, then it actually could hurt your sleep. Right, versus something you're reading that you're not that interested in. So yeah, trazodone, I don't know, discuss. It is 200 milligrams. It's a pretty high dose. You could even discuss decreasing it at least.
Decreasing it like to 100 and seeing how she does.
Right.
And then the other thing was the diclofenac, which is taken for presumably the osteoarthritis. The osteoarthritis was a lot in her hip and knees. One, diclofenac is when you compare it to there was a meta-analysis that came out that compared it to naproxen and I believe ibuprofen, but definitely naproxen was one of them. And it showed that it actually had a higher chance of having an MI with diclofenac compared to naproxen.
I think this lady had an MI.
She did. So this would be secondary.
Yeah, not good.
And the thought process with that, if the diclofenac is more so COX-2 selective. I'm pretty sure I'm right. I really should have looked that up.
No, I think that's right. Because
COX-2,
Celebrex is COX-1. Yeah.
Right. Or no, it's Celebrex is COX-2 inhibitors. This is most similar to COX-2.
Okay, never mind.
Ignore me. It's late.
Yeah.
Diclofenac is more similar to COX-2 inhibitors. And so, and this has been kind of tried to show that it wasn't actually, didn't play out in clinical trials with that precision trial. But the thought process for a while was if you block COX-2, then yes, you're going to get some inflammation reduction and you're going to reduce some of like the adverse effects with like the stomach and things like that. However, at that point, COX-2, you're getting prostacyclin as far as a product, and COX-1, you're getting thromboxane. So when you block COX-2, you have unopposed thromboxane production, which is a vasoconstriction. Vasoconstrictor over time increases, you're going to get higher chances of cardiovascular problems.
Great.
And that was the thought process between like when Vilox was taken off the market. Again, they tried to show with the Precision trial that there was no difference in cardiovascular risk when you compared Celebrex to naproxen and ibuprofen, but they used really low doses. There's some other sketchy stuff about that trial. I've talked about it many times, but my thought process would be either to stop the diclofenac, and if we had to use an NSAID, maybe naproxen, and try a lower dose like 375 twice a day and see if that works. But still going to affect your blood pressure. Still not great to be taken long term. So one, the duloxetine actually has evidence in hip osteoarthritis specifically, and will help again with the neuropathy and all that. So that may help. And then Tylenol is it's not a lot of evidence that Tylenol is all that effective either, but it may be something to consider, or at least maybe like a topical agent like Voltaren gel, which is still diclofenac, but you won't get the same systemic absorption.
I mean, you got to give Tylenol a try.
Yeah.
I mean, it's NSAID, post-MI, heart, with diabetes, kidneys, multiple reasons why an NSAID is just not ideal.
Yeah.
But
plus she's taking aspirin already, so she's trying to block.
Well, right now she's on Plavix and aspirin, and diclofenac and Celexa.
She's killing it.
Bleed risk all the way.
Yep.
Great. Good.
Yeah.
So I think we fixed her.
Maybe.
Maybe.
So yeah, that's kind of all we had for her. I know we said we were gonna do this in like 30 minutes. I think.
Well, we're always like, can we even get a full episode out of this? It's like 1 hour later.
But we were gonna hopefully be able to get a full episode. I think we made it.
I think we did.
So I'll post this. I have some questions too, because I actually gave this case to my PA students. So I have some questions at the bottom too, mostly geared towards diabetes, and I think 1 or 2 about smoking cessation and asthma. But I'll post this on the website under show notes if you guys want to take a look at it. And we'd love to hear your thoughts too, like what you would do differently or what you disagree with even. And
tell us why JNCH better than ACCHA, because I'm very interested to know.
And if you say bring up the diabetes thing that they weren't included in Sprint,
you're gonna get my going.
We're gonna talk about the accordion summary and the reevaluation of the Accord blood pressure.
Yeah, we totally talked about that. I'm telling you, that first episode was good.
It was solid. It was rock solid.
We actually did some research.
Well, we were fresh out of spending all our time with Dr.
I was
Word,
gonna say,
things like that.
I was right off of Dr. Bragg's rotation. And we had probably just gone to a barn grill the day before, so it was just spewing out.
We were this is just, we know the stuff on the top of our heads. 2 years later, still sort of kind of remember that.
Right, exactly. I had to memorize all the gold doses for the blood pressure stuff and heart failure, and I can't remember all of them anymore. So good. Got a refresher. Yep.
You got to hear, folks. Cool. All right. Well, I guess that's enough for tonight. Cole, go home and get some sleep.
Yes, sleep time.
Thank you guys so much for listening. Thank you guys for supporting the podcast, the comments, the ratings on iTunes. We appreciate all that. We also have some shirts, hats, mugs, all kinds of cool stuff with our logo on it.
Yes.
And so it's on our Shopify account, so you can get to that from Instagram. We're also linking through Facebook and some other stuff, so just keep an eye out for that. And then, if you guys have any questions, we'll have our emails in the notes, as well as you can reach us on any of the social media platforms, as always. So thank you guys so much, and we will see you next time. Later.